Hello everyone, welcome back to Tutor series. My name is Shujauddin and in today's lecture we're going to talk about renal cell carcinoma. So we're going to discuss the risk factors, the different syndromes renal cell carcinoma is associated with, the different kinds of renal cell carcinomas, their morphology, and a bit about the medicine, that is the clinical features and how to diagnose and what is the brief treatment of renal cell carcinoma. So starting off with the risk factors, so we're not going to waste much time on the risk factors because the risk factors are pretty much vague and you just need to know them on your tips. So the few risk factors that you need to know for renal cell carcinoma are obesity, people who are exposed to tobacco such as smokers, people who smoke a pipe, asbestos exposure, people who work in mines, etc. can have renal cell carcinoma. Apart from that, women who take OCPs or postmenopausal women who are on estrogen therapy, they are at an increased risk of renal cell carcinoma. Patients who have exposure to heavy metals, so all of these people have an increased risk of renal cell carcinoma. So I've written the list down over here: obesity, OCPs, petroleum, heavy metals, tobacco, and all of these are basically risk factors that can cause renal cell carcinoma. So coming on to the main thing, that is, we have different syndromes that can lead to renal cell carcinoma. So it's important to understand what each of these syndromes are and how do they cause renal cell carcinoma, right? So the first syndrome that we have here is VHL, which stands for von Hippel-Lindau, right? So VHL is basically a gene on chromosome number 3. Now, what does this gene do? The function of this gene is that it is a tumor suppressor gene. I'm going to write this down here. It is a tumor suppressor gene. So the function of tumor suppressor genes are that they keep regulating your body in a way that if you were to have any tumor growth, they would prevent that, right? This is the function of tumor suppressor genes. So they prevent carcinomas inside your body. So it's present on chromosome number 3, and if you were to have a mutation in the VHL gene, what would happen? Your gene won't protect you from cancers, right? They won't protect you from carcinomas and you will end up having renal cell carcinoma. So VHL has a strong correlation with renal cell carcinomas, and we're going to discuss that when we talk about the different types of renal cell carcinomas. So one thing to remember is that this VHL gene makes your VHL protein. Now VHL protein is responsible for regulating HIF, which is your hypoxia inducible factor 1, right? So VHL protein regulates HIF. Now hypoxia inducible factor is basically like, regulated by this protein. Now if this protein were to be damaged or if this protein were to be inactive, you would have uncontrolled levels of HIF present inside your body. Now what HIF does is that in cases of hypoxias, in cases where your body has reduced amount of oxygen, HIF causes a normal response inside your body, promoting angiogenesis, vascular growth, right? By increasing the number of VEGF, that is your vascular endothelial growth factor. So all of these things are controlled by HIF, and HIF is controlled by VHL, and this VHL gene is present on chromosome number 3. So if anything were to go wrong, you would have renal cell carcinoma, and we're going to discuss this further, but keep this point in mind. Now coming on to the different syndrome, which is hereditary Leo Myomitosis. Now hereditary Leo Myomitosis is basically a autosomal dominant disease. What happens is that you have the AFH, that is fumarate hydratase, present on. You have the AFH gene, fumarate hydratase gene. Now it is autosomal dominant, and if you were to have mutation in the AFH gene, you will end up having cutaneous leiomyomatous, you will have uterine leiomyomatous, and you will have renal cell carcinoma. So hereditary leiomyomatosis has a a strong correlation with renal cell carcinomas. I'll write down the gene here, which is your FH gene, fumarate hydratase, and mutation in this gene will lead to leiomyomatas inside your skin, your uterus, and renal cell carcinoma inside your kidney. Now coming on to renal papillary carcinoma, what happens in renal papillary carcinoma is, we'll discuss this further, but under the headings of syndrome, I'll just mention that renal papillary carcinoma basically has the MET proto-oncogene. So it has the MET proto-oncogene, and if you have mutation inside your MET proto-oncogene, you can end up having renal cell carcinomas. So we'll see that how all that happens, but renal papillary carcinoma is associated with MET proto-oncogene. Now coming on to Burke-Hogg-Dupe syndrome, which is short for BHD. Now BHD is also autosomal dominant, and it has the folliculin present. You have the folliculin gene. Now if you were to have mutation in the folliculin gene, you will have cutaneous lesions, you will have pulmonary cysts or blebs, and you will also have renal cell carcinoma. That BHD is usually associated with the subtype of collecting duct, or duct of Bellini carcinomas, and we'll discuss that under the heading of renal cell carcinoma. So briefly, the different syndromes that are associated with renal cell carcinoma is VHL, hereditary Leo Myomitosis, renal papillary carcinoma, and BHD. So now let's have a look at the different kinds of carcinomas. So the first type of carcinoma on our list is the clear cell carcinoma. Now this is the most common carcinoma amongst the different types. So what happens in clear cell carcinoma is that this is associated with VHL. So now over here, let's talk about this in further detail. Now you might have a different you might have few people who will have a deficiency of VHL. So you have two genes of VHL present in every normal human being. Now due to hereditary conditions, there might be people who have absent VHL genes on one chromosome. They're present on chromosome number 3, right? And you have 2 copies of each chromosome inside a human being, right? So if you were to have a only one gene present, you normally have 2 genes, right? But if you were to have only one gene of VHL present inside that inside a person, because they had deletion of VHL gene and because it's hereditary in nature, so now you already have one VHL gene, right? So nothing to worry about. But when that one VHL gene undergoes a hypermethylation or inactivation, that is when you have a increased risk of renal cell carcinoma. So it's important to understand that you might have people who would just have a single copy of VHL. They might not have 2 copies because due to hereditary inheritance. So but due to hypermethylation in that one copy, it would lead to inactivation, and then you would have renal cell carcinoma. So this is something to keep that in mind, that you will have hypermethylation of that one VHL gene. And like I said, that VHL is present on chromosome number 3. Now what VHL does is that it is going to regulate HIF, and HIF regulates your angiogenesis, right? So due to low levels of VHL, you will not be able to control HIF, and you will have high amounts of HIF present, uncontrolled high amounts of HIF. Now high amounts of HIF will lead to high amounts of VEGF, which is your vascular endothelial growth factor. High amounts of VEGF will lead to angiogenesis, and you will end up having renal cell carcinoma. So VHL has a strong relation with clear cell carcinoma, a subtype of renal cell carcinomas, right? So what would you see in the morphology of clear cell carcinoma? So a few things to note is that in clear cell carcinoma, you basically have clear cells, clear polygonal cells. you will have clear polygonal cells on morphology, and these polygonal cells will be yellow in color. Now the reason why they will be yellow in color is because they are filled with two things, that is your glycogen and your lipids. Glycogen and lipids are present inside these polygonal cells, which lead to the yellow coloration of these cells. You might also see hemorrhage and necrosis in these cells. So all of these things are going to be present inside the morphology. Now in the kidney, what are the different areas that get affected by renal cell carcinoma? So it predominantly affects your proximal tubular epithelium. Right, so it's going to affect your proximal tubule. Now in the proximal tubule, you have the straight and the convoluted tubule. So in either, you will have the proximal tubular involvement in clear cell carcinoma. Now one thing to note is that clear cell carcinomas tend to invade your renal vein. They have the ability to invade a person's renal vein. Now if you were to follow the track, you have the renal vein. Now this renal vein would turn into inferior vena cava, and then from the inferior vena cava it's going to enter your right atrium, then your right ventricle. So basically inferior vena cava and then your right side of the heart. So this carcinoma has the tendency to invade the renal vein, and from the renal vein it can also involve your inferior vena cava, and if left untreated it can also progress to involving your right side of the heart. So clear cell carcinoma is a bit difficult, and it's invasive as well. So it can involve your renal vein. I'm going to mention this here, so it's something that you really need to remember, that it can involve your renal vein, and from the renal vein it can make way through the inferior vena cava and go into the right side of the heart. So this is something that you need to know for clear cell carcinoma. And one thing to notice, that this is the most common type of carcinoma. Right, so keep this in mind. This one is the most common. Now coming on to the other type of carcinoma, which is your papillary carcinoma. So in papillary carcinoma, let's see what happens. So this name, I think we have discussed papillary carcinomas, have we? Yes, we have. We talked about it in the syndrome section over here. You have renal papillary carcinoma. So what happens in papillary carcinomas is that in papillary carcinomas, I mentioned that you have the mutation of your MET proto-oncogene. So let me write that down here. You have mutation in your MET proto-oncogene. We'll see what this gene does. So let's talk about what happens. I'll mention this here, that in clear cell carcinoma, where do you have the problem? You have the problem on chromosome number 3. So in papillary carcinomas, where do you have the problem? You have the problem in multiple chromosomes. So you can have trisomy 7, trisomy 17, or deletion of your Y chromosome in males. So papillary carcinomas can happen in a patient due to multiple reasons: trisomy of chromosome number 7, trisomy of chromosome number 17, or deletion of the Y chromosome in a patient, right? So clear cell carcinomas can happen due to two reasons. It could be sporadic or hereditary, and in either of the cases, what will happen? You will have a deletion, inactivation of your VHL gene present on chromosome number 3. Now, just like that, papillary carcinomas are also hereditary and sporadic in nature. So if you were to have sporadic papillary carcinomas, you would have all of these things, right? All of these things can lead to sporadic papillary carcinomas. But if you were to have the hereditary type of papillary carcinomas, in that case, for hereditary papillary carcinomas, you will just have this. Trisomy of chromosome number 7 leads to hereditary papillary carcinomas, while the rest including trisomy 7, lead to sporadic papillary carcinomas. So this is something that you need to know. Now, what does the MET proto-oncogene do? Because all of these lead to mutation in your MET proto-oncogene. So the MET proto-oncogene further controls what? It regulates the tyrosine kinase receptor of hepatocyte growth factor. Right, so, and one thing to note that, let me underline this so that, yeah, here you go. So in papillary carcinomas, you have mutation in the MET proto-oncogene, which controls the tyrosine kinase receptor for hepatocyte growth factor. Now, hepatocyte growth factor is responsible for cell growth, cell mobilization, invasion, like, normal architecture. All of these things come under the function of hepatocyte growth factor. So if you were to have mutations in the papillary, in the MET proto-oncogene causing papillary carcinomas, so what would the morphology look like? You will have papillary cells, right? Like the structure on morphology would be papillary. Like over here you had clear cell carcinoma. So what did I say? You will have clear polygonal cells on morphology. Now in papillary carcinomas, what would you see? You will see papillary structures. Now the cells could either be low columnar or cuboidal in shape. So let me mention that. They will either be low columnar or cuboidal in shape, right? So on morphology, apart from that, you would see interstitial foam cells present in between the whole tissue. So interstitial foam cells, and with that you will also see one thing, that is Samoma bodies. Now what are Samoma bodies? Sorry. Now, if you would remember, Samoma bodies are basically your calcium concretions, right? Like they are a collective, accumulation of calcium inside a tissue. So, Samoma bodies, interstitial foam cells, and low columnar or cuboidal cells would be present and seen on the morphology of a tissue which is involved in papillary carcinomas. Now, one thing to know is that papillary carcinomas are of two types. You have a type 1 and you have a type 2. Now the reason that I mentioned type 1 and type 2 is that the type 1 papillary carcinomas have a good prognosis, while the type 2 papillary carcinomas have a poor prognosis. So you there's a bit of difference on the morphology, but that's not needed at your level. At your level, what you need to know is that what would you see in papillary carcinomas and the two different types, that is type 1 and type 2. Type 1 has a good prognosis, while type 2 papillary carcinomas have a poor prognosis. So up till now we talked about two major carcinomas, that is clear cell carcinoma and papillary carcinoma. So let's come on to the other types of carcinomas that are also come under the heading of renal cell carcinomas, that is chromophobe carcinoma. So chromophobe carcinomas, they have a good prognosis. So chromophobe carcinoma. Now first thing to remember is that they have a good prognosis. So yeah, if a patient has chromophobe carcinoma, you don't have to freak out. They have a good prognosis and patients usually do recover. Now what happens in chromophobe carcinomas is that you have the intercalated cells of your collecting ducts involved in chromophobe carcinomas. So which cells are going to be involved? The intercalated cells that are present inside your collecting ducts. Intercalated cells. Now over here we had trisomies, over here we had deletions. So over here the reason why a person would develop chromophobe carcinoma is hypoploidy. Now what is hypoploidy? Hypoploidy is basically reduced number of chromosomes. right? So reduced number of chromosomes leads to hypoploidy, and patients with hypoploidy can develop chromophobe carcinomas. Now chromophobe carcinomas, under their morphology is that you would see eosinophilic cells, they will be eosinophilic, and they will have a perinuclear halo, that is a halo surrounding the nucleus. So perinuclear halo. Now perinuclear halo is specific to chromophobe carcinoma. So if in a question you are mentioned that a specimen was taken out and under the microscope it was found that the cells showed a halo, a perinuclear halo, anything with the word halo, that is chromophobe carcinomas, right? So perinuclear halos are specific to chromophobe carcinomas because you don't see any of these in any of the carcinomas, in the different renal cell carcinomas. So perinuclear halos are important. You will have eosinophilic cells present, and which cells get affected? The intercalated cells of your collecting ducts are what get affected in chromophobe carcinomas. So coming on to the last type of renal cell carcinoma, which is basically your collecting duct carcinoma or duct of Bellini carcinomas. So coming on to your collecting duct carcinomas. Now your collecting duct carcinomas are related to a syndrome, and amongst all these syndromes, what do you guys think? Which syndrome would it be related to? It's related to BHD, right? Birt-Hagdorf-Dube syndrome. So in collecting duct carcinomas, which part of the kidney is involved? So you have the collecting ducts of your medulla that are involved in collecting duct carcinomas. So which tissue will be which part of the kidney? The medullary part of collecting ducts. So your medullary collecting ducts are what are involved in the collecting duct carcinomas. Now medullary collecting ducts are this type of carcinoma has a similar morphology to your medullary carcinomas that you tend to see in sickle cell patients. If you guys remember from your hematology module that in the sickle cell anemia, patients tend to have sickling inside their blood when the blood passes into the medulla, because in the medulla you have stasis, the blood passes slowly, you have reduced amounts of oxygen, and it takes an increased amount of time when the blood passes through that. So in patients of sickle cell anemia, you have medullary carcinomas, and medullary carcinomas have a very similar morphology to medullary collecting duct carcinomas, that is collecting duct carcinomas here. So they involve the medullary collecting ducts. On morphology, what you would see is that you will have a hobnail pattern in the carcinoma of the collecting duct. So what do I mean by hobnail pattern? So in hobnail pattern, what happens is that when you see under the microscope, you have a bulging nucleus that is very much appreciated when you look under the microscope. So hobnail pattern. And you will have a irregular tissue growing, irregular architecture. So I'll write that down here, irregular architecture. So hobnail pattern, you will by hobnail pattern I mean bulging nucleus. So under the microscope, what would you see? A bulging nucleus would be appreciated from the cell. And you will have irregular architecture, and it involves the collecting ducts that are present inside your medulla. So these cancers are low yield compared to the clear cell carcinoma and the papillary carcinomas, because they do not have a good prognosis, while these do have a good prognosis. They are treatable and they are rare. And one thing to remember is that collecting duct carcinomas have an association with BHD syndrome. So you could have a patient with pulmonary complaints, because in BHT syndrome you have pulmonary cysts or blebs present. Apart from that, you can have skin problems, and you can also have collecting duct carcinomas in a patient with BHT syndrome. So either of these carcinomas can come present to you with a few clinical features. So when we talk about the clinical features, one thing to remember is that you have a sort of a triad when it comes to renal cell carcinomas. So what is that triad? So the triad for renal cell carcinoma has, obviously it has three things. So the first thing is palpable mass. Now, as you would know that whenever we talk about cancers are rapidly growing, right? Like they have a increased cell turnover, they have a lot of mitosis going on inside the cell, right? So they tend to grow in size. So when you have the involvement in your kidney and you have a renal cell carcinoma, your kidney is going to grow in size, right? So you will end up having a palpable mass on the physical examination of a patient of renal cell carcinoma. So a palpable mass is going to be present. Apart from that, you will have flank pain. Obviously, flank pain or costovertebral pain, they're all the same. Why would you have pain? Because you have a increased organ growing inside your abdomen, right? It's a retroperitoneal organ present inside your abdomen. So it is going to obviously have a lot of discomfort in the patient. Apart from palpable mass and flank pain, what would you have? You will also have hematuria. Hematuria is basically blood in urine. So this is basically the triad of renal cell carcinoma. It's not necessary that you have all of these things present, but yes, these three things can be present all together in a patient, and this is a sort of a triad that you get to see a patient with. Now, apart from these clinical features, now one thing to remember is that the renal cell carcinomas, they tend to become symptomatic when they're in the late stages. In the early stages, it's usually asymptomatic, they're silent, which is why you cannot catch renal cell carcinomas. So when a carcinoma has increased approximately 10 centimeter in size, that is when they tend to show symptoms, and when you get yourself evaluated, it's already too late. But you usually don't have symptoms in the early stages, you get symptoms afterwards. So these are the classical symptoms. Apart from these symptoms, you have paraneoplastic syndromes that happen with the renal cell carcinomas. Now, when we talk about the kidney, your kidney regulates a lot of things. It produces erythropoietin, it controls your calcium, it has 1-alpha hydroxylase, right, which is involved in the calcium and vitamin D regulation. Apart from that, it also controls your phosphorus, it also controls your blood pressure, I mean the renin-angiotensin system, the aldosterone system. All of this is controlled by the kidney. So when you have a carcinoma going on and when you have a deteriorating kidney function, you tend to have these few symptoms coming to you. So what are the few symptoms that you get to see in a patient of renal cell carcinoma? So the first thing would be polycythemia. Now, why would you have polycythemia? Because of increased amounts of erythropoietin. High amounts of erythropoietin lead to polycythemia in patients of renal cell carcinoma. Apart from that, you will also see hypercalcemia. Now you will have hypercalcemia because of increased parathyroid hormone, because you have a deteriorating kidney function. So you can have hypercalcemia present. Apart from that, due to multiple paraneoplastic syndromes, you tend to have hypercalcemia. So due to poor kidney function, and paraneoplastic syndromes. Now, apart from hypercalcemia, what would you also have? You will have hypertension in these patients. Now this hypertension could either be because of your kidney not being able to regulate the blood pressure properly. Apart from that, the hypertension can also be because of Cushing's syndrome, because in patients of renal cell carcinoma you can end up having Cushing's syndrome as well. Like I said, renal cell carcinoma is associated with a lot of paraneoplastic syndromes, so Cushing's syndrome can also be present. And as you know that in Cushing's syndrome you have increased amounts of cortisol, and cortisol can raise your blood pressure because it does, or it also has a few characteristics that resemble mineralocorticoids, right? So you can have Cushing's syndrome as well. Apart from that, you can have two different syndromes, that is Stauffer syndrome and limbic encephalitis. So in Stauffer syndrome you have increased amounts of LFTs. Apart from that, you have decreased liver function, and you also have a poor clotting. So this is present in Stauffer syndrome, which is related to the renal cell carcinoma. Apart from Stauffer syndrome, you have limbic encephalitis. Now in limbic encephalitis, what happens is that you have psychosis, memory loss, so in psychosis, you basically you have a lot of hallucinations, delusions, all of these things happen. So in limbic encephalitis, you have psychosis and memory loss. So all of these things are related to renal cell carcinomas. That so these are basically the clinical features. So when you tend to have these clinical features, you need to evaluate the patient for renal cell carcinomas. Apart from that, one thing that you two things that you get to see as well is that renal cell carcinomas are also associated with varicocele. So in a patient who presents with varicocele, you need to see if it's just due to any pathology, or it's because of renal cell carcinoma. So you need to evaluate the patient. Apart from that, these patients can also have Budd-Chiari malformation. So what happens in Budd-Chiari is you have thrombosis of your hepatic veins. So these are the clinical features. Now when you have a patient who you are suspecting for renal cell carcinomas, so obviously you're going to order their renal function tests, but what you need to do is that you first need to order a abdominal CT scan with contrast to see if you have the kidney, and if in the kidney you have any irregular thickening, any tissue. Obviously when you're going to administer contrast, you'll be able to see the kidneys properly and any pathology inside the kidneys. So abdominal CT scan with contrast is going to be your diagnostic measure. Apart from that, you can also order MRIs. Now those MRIs are going to be to see if there is any metastasis in the body. So renal cell carcinomas can metastasize to your lungs, they can metastasize to your brains as brain as well. So, and they tend to metastasize before any symptoms. So one thing to note with renal cell carcinomas is that before having all of these symptoms, the renal cell carcinoma will have had grown inside the patient's body and would have also metastasized, and after metastasizing it presents with these symptoms. So you can imagine that when a person is going to have symptoms, they will probably be on their stage 3 or stage 4 of renal cell carcinoma. So coming on to the brief treatment, so what you can do is, if a patient has obviously everyone is going to have two kidneys, right? So if you have a poor functioning kidney with a renal cell carcinoma, so you completely remove that kidney, which is called radical nephrectomy. If you can if you see that the kidney with the cancer is operating well, you just have a a simple lesion, so what you can do is you can remove that lesion as well, so instead of removing the whole kidney. So that depends on the approach, depending how much the cancer has spread and how much the kidney is functioning, right? So it's either radical nephrectomy, that is removal of the kidney completely, or partial nephrectomy, that is removal of a tissue of that affected kidney. So with this, we come to the end of this lecture. I hope that you guys were able to grasp the whole concept behind renal cell carcinomas. But if you guys have any questions, feel free to reach out to us on our Facebook page or leave them down in the comment section. Thank you so much for watching.